and start. Can you start recording, Michelle? Thank you. That was your reminder. This meeting is being recorded. These recordings are uploaded to our cost growth target tag website as soon as we are able to. Another reminder, if you haven't already, to go ahead and edit your name in your Zoom profile to show your full name and the organization you're with. And yeah, we're aiming to end at 10 a.m. and give people an hour back of their day. And it looks like we've reached critical mass, so I'm gonna start going down the list of usual suspects, or rather frequently attending organizations, tag members. So I'll just run down the organization names, and if you have, and if you're a staff member from there, please announce yourselves for the group. If that doesn't work, you could also announce it via text in the Zoom chat box. All right, so I'm going to start with data submitters. Are there any folks from Advanced Health? Okay, what about people from All Care?
This is Ada from All Care.
Hi, Ada. Okay, Care Oregon. Right, Cigna.
Good morning, it's Jason Loftus from Cigna, and I also have Jean and Sashank with me from Cigna.
Jean and Shashank, thanks, Jason. CVS Health, Aetna.
Hi, Tracy Cole is here, Alicia DeJesus, and John Navickas.
All right, thank you. Good morning. Any folks from Health Share? Going down the line, Humana.
This is Carrie Foreman.
Hi, Carrie. Okay, Kaiser.
Hi, this is Keith Cronin from Kaiser Permanente.
Thank you, Keith. Moda Health. All right. Anyone from our own Medicaid, representing Medicaid fee-for-service data submitters?
Yeah, Chris Kuhn is here.
Hi, Chris. Pacific Source.
Hi, this is Jeanette Sims from Pacific Source, and I have Kyle Harada and Angela Mankraus with me today.
Hi, Jeanette and Kyle and Angela. Providence?
Hi, this is Don Cantoria, Providence Health Plan.
And Andrew Tarab from Providence Health Plan.
Good morning. What about Regents and Cambia Health?
Hi, it's Vince Porter, and I think Jared Collins is also on the phone, on the call.
I'm here as well. Thanks, Vince.
All right, thank you. Samaritan Health.
Hello, this is Wade Penner.
Hi, Wade. What about any folks from Trillium or HealthNet?
Julianne Duncan's on the line.
Thanks, Julianne. How about Umpqua Health Alliance? Moving on down, what about United Health?
Hi, this is Laura McDonough from United Healthcare with Pete Hindle.
Good morning. Okay, and then Yamhill CCO. All right. Going to OHA folks. There's myself, Trang Weidemeyer. I saw Sarah Bartleman. Any other
Kim Rose.
Folks from OHA? Hi, Kim.
Hi, Stephen Ranzoni from OHA.
Liz McCarthy from OHA.
Hi, Yishan Song from OHA.
Cypress Clark from OHA.
Ben Chan from OJ.
This is Zachary Goldman, OHA.
Sam Smith, OHA.
All right, thank you. Okay, any folks from Baylet Health? Okay, now we're in the other participants category. Any folks representing legislative offices, other state agencies, analytics consulting organizations, provider groups?
This is Richard Gibson from Comagine Health.
This is Rebecca Owen from HCAS.
Holly Pfeiffer from HCAS.
Okay. And are there any public attendees attending this morning? Members of the public? Hearing none, I think that will include our roll call at the top of the hour. Thanks, everybody. All right. Oh, yeah.
I didn't hear Cascade Health Alliance called, but this is Donna Oakson from Cascade Health Alliance.
Oh, hi, Donna. I'm not sure how I missed you. Okay.
And Danielle
Thanks, I've got
Sherman
you
is on as well with Cascade.
Okay. Hello. Good morning. Apologies for skipping some out. Okay, are there any other people on the line that I also skipped over?
Hi there, this is Chris Hogan from Advanced Health. I just jumped on.
Thank you.
This is Larry Sutterberg from YCCO. I just jumped on as well.
All right. Any other people? Oh, and I see Jim just entered, also from Advanced Health. Okay. All right. So let's continue forward. The slide Michelle has up right now. So this is our meeting agenda, our tag agenda for today. We canceled the September tag meeting, so we'll briefly go over the August tag meeting, which was fairly short itself because we also used it as a rack. We'll go talk about some updates relevant to the program. And then Sarah and Stephen are going to talk about this intensity analysis and how we've sort of been thinking about the approach to this. And then we'll do a wrap up. I can't believe the year is almost over. Okay, next slide. All right, so the August meeting summary, those notes are going to be in the September TAG meeting section on the TAG website. And very quickly, we talked about this future 2022 advisory committee that's going to be taking over governance of the program from the current implementation committee. Recruitment has just ended for members, candidate applications for that group. And Sarah and the rest of the team will be working to winnow those down to present to the board. At that meeting, we also talked about the validation tracking. We presented, those stages. That's also where we spoke about how best to communicate these results to TAG members, and everybody pretty much agreed that maybe an internal weekly email update would be best. So we're doing this at an aggregated level. You can see the sort of the tables later on at what it looks like. It's a very summarized look at how it's going, but it does give you an idea of how the files are going through validation and stuff like that. And then we also had a quick little section for any Q&A at the end. That August TAG meeting was fairly short because we used it to hold a rules advisory committee meeting for the data submission rules. So thank you for those who attended and gave feedback for that. The rules have gone through the rulemaking process, and period for public comment just ended. So they will go into effect, I believe it's around mid-November. And they're pretty much the same as the temporary rules, except we removed the language that was referencing this special initial data submission year. And then, yeah, the September meeting was canceled, so we just gave an update via email. So now let's go on to a couple updates, a couple programmatic updates on the advisory committee. We'll give an update on how validation is going and some common issues we're seeing, which would be really great also because there's a number of data submitting entities that have extensions. So sort of seeing what the early submitters look like might help you vet your file before submission. And then, as always, since there are still files waiting to be submitted, we'll review some data submission resources, which haven't really changed since last time. Next slide. And here I'll hand it off to Sarah to give an update on advisory committee recruitment.
Thanks. Good morning, everyone. So Trang mentioned that we had open applications for the new cost growth target advisory committee that will launch in 2022. The applications closed on Friday, the 22nd of October. Thanks to everyone who applied or helped get the word out or pushed it out to your networks. That was really appreciated. We had a large number of applications, which was great. As Trang mentioned, we are pulling together all of the applications, and we'll be bringing an update to the Oregon Health Policy Board at their meeting on Tuesday next week. The Policy Board is the group that will appoint the advisory committee. This will be a committee of the Policy Board. So we expect some discussion with them on Tuesday. And then depending on any remaining gaps in expertise or representation that we still need, we might do a little bit more targeted recruitment to fill those gaps in November and then come back to the policy board with a final slate of membership for approval at their December meeting. So for those of you who have applied and wondering when you're going to hear back, it's probably not going to be official until December. Those of you that are wondering if there's still an opportunity to apply, applications have officially closed, but we might still reach back out and we might still ask for applications or nominations for specific expertise or representation, depending on where we see those gaps. So I should know more in the next couple of days, and the next update on this will be at the policy board next week. And I think that's it. Any questions about the committee recruitment? Okay, thanks.
Double muted. Okay, so now let's get into validation status update. Next slide, please. Great. So first of all, thank you for those who gave feedback to our validation process and those three, how we kind of broke it out into 3 stages. It's largely been working just as we thought. We've made a couple tweaks. But I think we're overall pretty happy at how it's going and appreciate everybody in working with us and replying very quickly when we do reach out to validate files. We also want to highlight some early, because we have already held a lot of early data clarification chats, we've been able to refine it even more, and we wanted to bring some of that to you folks today. Also, I want to give a particular shout out to Liz McCarthy, who has been vital in this process on our side as well. Next slide, please. So there have been a couple process improvements. Nothing really has altered the core of the stages. And you can see those, I think there's a link to it. You can see those stages in the data specification manual on page 33. But some of the process improvements, after going through some initial files and some back and forth with data submitters, are outlined on this page. I don't think I'm gonna go through every single one on this page, but you can see there's a range of things. Some things we didn't expect, and there's been a lot of, not revisions for this year, because this year is already happening, but improvements we can push forward to the CGT1 template for next year. A big, probably the biggest change also is related to the most common issue we've seen, and it's that the provider attributed data is parsed out a little more granular than we were expecting. And so you can see that second bullet point, an extra check for unique combinations of those data fields only exist in one row. We don't have to hash this out, but you can see all those checks. And if you have any questions, please feel free to reach out to us. But we do want to talk a little bit about some common data validation issues we've seen among the files. So next slide, and I'll handle, I see Ada has a question right now. Will the template be updated if TME Prov is not meant to be provider specific? The template, well, I'm not really sure about edits, but we could be definitely more specific in our instruction. Yeah, do you want to take this?
Yeah, let me take this one. So I don't think we plan to update the template at this point. We went back and forth on this a lot in the early days of planning. Some of you might remember these conversations because there are some provider organizations where the organization name is actually the provider name. So that's why we have that first last name field in the template. That may not apply once things are rolled up. There may only be the organization name. So I don't think we're going to change the template because we need to accommodate both of those scenarios. I think we just want to provide a little more clarity and guidance and probably a lot of individual conversations with you about what the options for rolling that up look like. And I know Chang's going to talk about that on the next slide.
Yeah, so can we go to the next slide, Michelle? I have an example of what not to do and what to do. Oh no, yes,
What,
this is the right slide.
and to caveat, sorry, Chang, I think what not to do, what to do, where possible. We know that there's variation. This might not be possible in every single situation, and just want to say that up front.
Yes, so provider, for the individual person provider, that last name field and the first name field, blanks are allowed. So, and this is probably the most common issue we've been seeing so far, is that we are getting files that are listing the provider organization name and then creating separate rows for each individual person provider under the same organization. So what we're seeing is a lot of provider tabs that look like the left-hand side of the screen, where the provider organization name is Health System A, and then the last and first name field has been populated for different provider names, which we don't need and which we're not expecting. It's not how our aggregation is handling this data. So what we want and what should be reported in the file is on the right-hand side, just Health System A and leaving last name and first name blank. I've left out the other fields such as year, line of business, and attribution hierarchy code, but this is assuming all of those are the same. So you don't need to, you shouldn't give us the red table, you should give us the green table. Unless, of course, for example, Harry Potter is their own independent provider. They don't belong to a larger group or system. So in that case, you can, that's where we are also seeing some names in the provider org name field, and that is okay. And as we're seeing them, some issues, some data issues, it really depends on what the file looks like. I'll mention this later on, but I'll go ahead and say it here. If we are able to remediate this from our end, we are more than happy to do that. But a lot of these roll-up issues, we don't have your data, like we can't do that on our end. So in some situations, a resubmission is needed, and it's really dependent on the file. So a data clarification conversation should surface that.
Let me jump in. I think I see a second question in the chat about having to resubmit to resolve that. I think what we're experiencing is that each file is different and each conversation about what's going on in the file is different. And I really don't want to give any blanket direction on the call today about, yes, this absolutely means you have to resubmit or this doesn't. I think we have to have an individual conversation with you because the resubmission may be dependent on other issues, or it may be that you used an older version of the template, which is totally fine. But if you have to resubmit for a different reason, we're going to ask that you use the current template in that resubmission. So these factors are all sort of interrelated, and it makes it really hard to give any sort of blanket direction that you can all generically apply to your situations today. So I'm sorry for that. I know you probably want more clarity, but I think what we're finding is this really has to be an individual conversation with each submission.
Perfectly said, Sarah. This really is an individual conversation because each file is very unique in and of themselves. Yeah, so that's probably the most common issue we've seen. Sort of related to provider organization reporting, we're also seeing some discrepancies between provider organization name in that provider tab 3 where it is not populated in tab 7, which is the tab where you have organization name, and you can put any affiliated TIN associated with that organization. So there's a little bit of discrepancy there in the files we've been seeing so far. And we just wanted to highlight these provider organization level reporting discrepancies. We're really hoping they could be resolved correctly, quickly, because this is at the crux of creating that statewide file. We know the way the data is being submitted in the template, with that organization name and the provider names being a free text field. Those are free text fields, and it's going to require a significant amount of time to wrangle it all together. And thanks to conversations in this tag group, we created that tab 7 field to link it to TINs, which are more stable than NPIs over time. So we're really depending on that tab 3 and tab 7 making sense together, not just for your own file that each payer is submitting, but for the larger statewide file too. Do you want to add anything, Sarah? Okay. All right. Let's go to the next slide. Some other data issues we've seen, some of them are pretty minor, but these are also just common ones we wanted to bring to everybody's attention. Provider organization rows in that provider tab with 0 member months, which shouldn't happen. And I think for some of the files we've seen, it's just a relatively easy coding fix. Any people that are attributed to a provider organization, they should have some number of member months. So we are expecting, we shouldn't see rows with 0 member months. Because if people are attributed to them, even if they didn't visit, even if they didn't incur any claims for that organization, those member months should still be there. Other things we've seen are a little bit of wonkiness with the risk-adjusted standard deviation, PMPM. Sometimes it's high, given other data that we're seeing in the file. That doesn't mean it's necessarily wrong, but that is something we'll bring to you in our when we send out those data clarification emails, just so you can check your standard calculation on your end. Other things include discrepancy in those PME tabs, the tabs 2 through 4. So tab 2 is sort of the big picture overall by year, line of business, the expenses for those categories. The line of business code in the TME all, TME Prov, TME unattributed, those lines of business aren't exactly the same as the market enrollment categories in that market enrollment tab, but they should line up. A good kind of an example to look at is we have 6 lines of business that you can use in tabs 2 through 3, TME all, Prov, and unattributed. Medicare, 2 of those lines of business are for duals, Medicare expenses for duals and Medicaid expenses for duals. So those are 2 separate rows. But in market enrollment, we just have 1 category for duals, for Medicare, Medicaid duals. So theoretically, those 2 lines of business should equal, the member months should, from TME all, they should equal that enrollment category. So we're seeing some discrepancies there in a couple of files. And if we do, we'll bring that to your attention. And then lastly, not using the most recent template, which is version 1.4. That version was posted in August because we found an error in the formula. And we emailed it out, but I can of course, which is kind of a good sign. Of course, people probably have already started populating the template using older versions. So I'm seeing the silver lining in that folks were using the earlier version.
And I would also add that, sorry, go ahead, Trey.
Oh no, I was just gonna say, that's not a lone cause for resubmission. If you used an old version, the data you report in the old version of the template, we can move it to the new template. But if a resubmission for your payer is necessary anyways, we will ask you to use the new template that's posted.
Yep, that's exactly what I was going to say, that just using an old version of the template is not a cause for resubmission, and we can fix the formulas if needed, and all of your data will be fine.
Yeah, there's a few things, there's a few data issues where, and this brings me to the green text at the bottom of this slide, where we'll bring all issues to you, and if they can be resolved without a full file resubmission, we'll definitely go down that path. So please keep that in mind as we reach out for data clarification. I think this week we're going to try to push out the last of them for payers that have submitted files to us thus far. Are there any questions or anything else to add from Cost Growth Target folks?
We have one more slide about the process. I think we do.
Yes. Oh, yes. Actually, can you go forward a slide? All right.
This is Tracy Cole. Can I ask
Yes.
a quick question? The version dated 8/31. I'm sorry, it's dated 8/31 on my end. What was the date of the 1.4 on your end for the data submission template? The date that it was updated?
I remember it was August. I don't know the date, but the version number should be on the first tab of the Excel workbook. Yeah.
All right, thank you.
Mm-hmm. Okay. And we wanted to throw up some validation Q&A right here for people wondering, what if I haven't heard back from OHA about my file? Do I need to do something? In this case, no news is good news. We are reaching out to data reporter contacts for data clarification. If you don't hear from us, that means your file has probably gone through stage 1 and 2 good enough to reach stage 3. There might be issues. Well, during stage 3 conversations, we'll present the outputs of stage 1 and stage 2. It doesn't mean that there aren't questions, but you'll see all those validation outputs in stage 3. If we're reaching out to you for data clarification, that's because we found something in the file that is preventing it from reaching stage 3.
And I want to add that Trang mentioned this a few minutes ago, but our goal is to have all of those initial emails out about any clarification conversations by the end of the month. So no news is good news. If you're going to hear from us about data clarification stage 1 or 2, it should be in the next couple of days.
Yes. And what if my second question, what if my team found a reporting error and we've already submitted our CGT1 file to you? So if you've already found something, please reach out to us right away. Chances are your file has already gone through some, if not all, of the stage 1 validation checks. and if a resubmission is necessary, we will give you the notes we have on your file thus far and work with you as you do your rebuild. Okay. Any other things related to validation? All right, let's move along to data submission resources. So next 2 slides, Michelle. And I can see in the chat, there's a payer-specific question that Sarah commented on, so we'll reach out to you later about that. Thanks. Okay. So this is the same list of submitter resources that you've seen before at these meetings. Wanted to highlight the CGT1 template version to use is 1.4. For those of you still in the middle of compiling your file, if you have extensions. Any questions before we move on to analytic planning? And I see we only have 20 minutes left to Sarah and Stephen, so sorry for taking up so much time. And if you have any questions about your file, if you've submitted a file, reach out to us. If you haven't submitted your file yet, definitely bring us questions as you go along. I know a lot of you have, and we really encourage that to get the best file we can by the time it hits our inbox. All right, thanks. Now I'll hand it over to Sarah and Stephen to talk about this intensity approach.
Thanks. Okay, so we wanted to take a little bit of time with you all today for one of the other purposes of having a technical work group for the cost growth target program. So while we are spending the bulk of our time focusing on collecting, validating, analyzing the data, and reporting on cost growth target performance, we also are working as a team on a number of other analyses, and as part of our data use strategy. So we want to have supplemental reporting, mostly using our all payroll claims data, other data sources as well, to think about cost growth and cost growth drivers. So we want to drill down. I think we've talked about this a little bit before. We've certainly talked about it a lot with the implementation committee. And our team has been working through a series of analyses that we're planning and working on for supplemental reporting. And we've hit a sticky spot, and we wanted to bring this to you all for some discussion today because we really value your input, and we thought having some more analytic minds on this would be helpful. There's not a right answer here, and I want to just preface this with, we're not looking for a decision today. This isn't a policy direction or a conversation. This is more just we're spinning our wheels a little bit, and we thought it would be helpful to bring you all into the conversation. So what we are talking about specifically, this all comes from some work that is being guided nationally. So Oregon is one of 6 states now, actually Rhode Island just joined in the Peterson-Milbank program for sustainable healthcare costs. So states that are developing cost growth target programs are collaborating, receiving some technical assistance, helping each other brainstorm these types of issues. As part of this technical assistance program, a white paper was published this summer to help states develop these supplemental analyses to help understand cost growth drivers. So you can see there's a link to the report here, and I think it was also sent out as a meeting attachment in case anyone wants to dig into the weeds with us. But really, we're talking about 2 different types of reporting. There's standard analysis to inform, track, and monitor impact of the cost growth target. Most of those analyses in bucket 1 are coming from the data submission templates, the files that you're providing, or using that data directly. But then we have these ad hoc analyses that will use other data sources and look at all kinds of other things. And this data use strategy guide really is focused on what to develop and what could be developed in category 2 here. Next slide, please. So in this data strategy document, there is a proposed framework for these analyses. So looking at where spending is problematic, and again, that would be using the CGT1 data, the data submissions from you all. And then there's the deep dives to understand what is causing the problem. And it's recommended that states look at a couple of different angles here. So price, volume, intensity, population characteristics, and provider supply. And then we get down into different levels of drill down and what stratification and granularity might be possible. But we really want to focus here on what's causing the problem in this ad hoc analysis. Next slide. And one more slide. So we're going to focus specifically on intensity today. And I want to start with the definition that is in this white paper. So what is intensity? Service intensity refers to the scope and types of services utilized for treatment. It captures differences in the site of care, for example, inpatient versus outpatient, and treatment modality, for example, robot-assisted versus manual surgery. Service intensity is complex to capture analytically. If it is not captured, it can be masked as a change of price, for example, when a new expensive drug replaces an old one. Service intensity is often referred to as service mix or provider mix. And most critically, there is no standard method for assessing the impact of changes in service intensity. So this was our guidance that we had, like states should think about doing intensity analysis, but then also there's no standard analytic approach to do this. And there's also not a lot of agreement about what intensity analysis really even means. So next slide. And when we started thinking about this, our team realized that intensity really covers a lot of concepts. So we tried to create some grouping and tried to organize this conversation a little bit more. So some of the concepts around intensity relate directly to the patients and the individual members. So this is where you have things like risk scores, risk adjustment, case mix analysis, acuity. Are your patients getting sicker? Is your panel getting sicker? Is that what's driving the change? Then there are concepts that are directly related to the services that are provided to those patients, regardless of any change in the patients themselves. So service intensity, unit price analysis, upcoding, same service provided to the same patient, but maybe documented differently, same service provided to the same patient, but maybe at a higher price. So again, you can see there's a lot in here, and trying to tease out the different pieces of essentially an overlapping diagram could get pretty sticky really fast. Next slide. So we also spent some time trying to articulate what it is that we think it's important to measure in this intensity conversation. And a couple of things came to the top for us. So one is substitution of service. So is it possible to identify analytically when a patient or a member who has the same condition or needs the same treatment receives a different, a more expensive or a more invasive procedure than they could have received? So this is something like a CT scan instead of an X-ray. Something that's higher acuity, or not higher acuity, higher intensity, more expensive potentially. Could this substitution of service be what's driving spending growth? In other words, how much of the total spending increase or the spending growth that we can see is due to changes in service intensity? What is the thing that's most important to target? And this is where we want to spend our focus. This is what we want to try to understand how to analyze. We know that if we just say, okay, prices, it's utilization, that's some level of granularity, but that's not specific. There are lots of things that go into prices and utilization, and intensity is just one of those concepts. But also, this becomes a very slippery slope into things like clinical appropriateness. We don't know. It is maybe there were really good clinical reasons for that CT scan instead of that X-ray, and we don't necessarily know that we can get at that analytically. So we're thinking maybe on an aggregate level, are there some ways we can look at this and tease this apart?
And Sarah, I want to draw some emphasis to same condition or treatment. We really are trying to differentiate away from patient acuity being the reason for the intensity. And so it's important that we point out that we would want to look within patients of the same condition, within patients of the same acuity, receiving different outcomes or different types of services. So
thanks, Stephen.
Yep.
So just a couple more things for grounding. Next slide. We have been participating with conversations with our counterparts in a couple of other states to share ideas and potential analyses to try to better understand an approach for intensity analysis. And you probably won't be surprised to hear that every state has a different idea about how to do this. So For example, in Washington State, the Washington Health Alliance has a report that came out recently where they have looked at treatment intensity. They define that as the impact of more or fewer services used in treatments. For example, more units of service to deliver care, such as longer hospital stays, more advanced technology, and increased spending. They are using their claims data to look at inpatient spending. They're using a proprietary DRG software to break out price, utilization, and intensity. Next. Massachusetts has taken a slightly different approach. They are really focused on acuity, severity, and upcoding. So they found that although their commercial inpatient utilization has declined, their inpatient spending is increasing. It's driven by increasing prices and acuity, and they're finding that their hospital admissions are being coded at increasingly higher severity levels. So they're really looking at this as an upcoding issue and trying to figure out how exactly they can pull out that component of this. So part of an intensity analysis conversation with our definition, I don't know if we would call this intensity, but I think this is also one of the options that's on the table. And then finally, before I stop talking and ask for some feedback, we thought about this from two different ways. If we're thinking about how do we construct an intensity analysis that gets at what we think is important to get at, we think you could look at it from a top-down approach or a bottom-up approach. So a top-down approach would be to try to create those stratifications. So take that high-level view. We know how much total spending is growing. We know spending can be divided up by changes in price and changes in utilization. We know that utilization can be driven by membership and service frequency. There's some additional granularity that can be parsed out there. And the price side, we can tease out how much of that price is driven by the unit price changing and how much of that is driven by the service intensity. So one way to do this would essentially be to take away everything else that we can measure, and whatever else is left is intensity, sort of a leftover assumption approach. Next slide. The bottom up approach would be to try to very specifically, for specific procedures, for specific conditions, for specific treatments, identify in a way that's really informed by the literature, really informed by what we're seeing in the data and the code. Where are there places where treatments appear to be diverging from what we would expect to see for a given procedure, diagnosis, and age and sex sort of patient profile? So I'm hand waving a whole lot because I really want to get to discussion in the next few minutes, but this would be a way for us to work backwards. We would pick a specific procedure, look at the codes that are associated with that procedure, look at treatments that are associated with that procedure, with that diagnosis, and then identify where we see some differences in who's receiving what. This seems like a really labor-intensive approach. Is the juice worth the squeeze in this approach? But it also feels like it might get us something more specific and tangible than the top-down approach where intensity is just whatever's left over. So all of that said, I know there's a ton of concepts in here that we only hit really high level on, but wanted to open it up and see if you had thoughts, pros and cons of some of these approaches, other ideas for thinking about intensity. What does intensity mean from your organization's perspective? And I'll stop there. I see hands, so let's go Drew, Rebecca, and then Keith.
Thanks, Sarah. Drew Tarab from Providence Health Plan. One way I've approached this in the past has been to actually think of intensity as part of utilization and not necessarily part of price. When I was looking at the top down, you had intensity as part of price. The reason I was thinking that is in the past, occasionally the definition of a CPT code has changed, or you can't actually easily tease out utilization from severity or intensity, because sometimes something's accomplished in one visit or one unit of something, and another time something's accomplished in like multiple units of something, and it's the perhaps the inaccuracies or the vagueness of procedure code documentation. Whereas with unit price, it's possible using APAC data to take a market basket of services in year one and compare that same market basket of services in year two, and you could probably even control for patient mix also. But I was thinking if you isolated unit price more precisely, or accurately, you'd have a remainder, but that remainder would be called utilization severity. And I feel like, at least from my perspective and the health plan's perspective, Providence Health Plan perspective, we've been okay with sort of just leaving something labeled as use severity as one bucket, and not trying to tease out how much is utilization and how much is severity. No, giving the explanation that the procedure code definitions of like what is a unit isn't always clear, and so you get mix matching. Bundling, yeah, even do like bundling of services and things like that, it's sometimes hard to tease out what's use and what's severity. My 2 cents. Take it for what it's worth.
Thanks, Drew. Appreciate the 2 cents. I think it's that bundling. I think everyone that we've talked to, when we were trying to talk to the other states, we realized that we were all using the same terms, but they all had different bundles underneath them. So some of this has just been our attempt to try to get more specific about what we're actually talking about. So I think I hear what you're saying. Thank you. Rebecca?
So this is very interesting. And I'm often a bottom-up person, and I completely get why we might want to do that, but I also know that it is intensive. I wonder if it's possible for us to decide that some things are top-down, some things go in more of Drew's sort of market basket / bundles, which are clinically appropriate. It might be, like an outpatient surgery bundle, and some are more top-down, so that we have a way of making sure that we keep our perspective on the total intensity shift. And yes, you can see intensity shift, the total intensity shift compared to what we've got our microscope on at any given time.
Thanks, Rebecca. Keith?
Yeah, just building on the comments that have already been made, I think either approach in itself is going to be a huge amount of work. I think you need to probably look at a hybrid approach. And there is definitely difficulties around definition. And if you've got things changing and there are different procedures, then a lot of your unit cost analysis, you really need to go down and look at those groups of things, but that could be very time intensive. So I think if you've got some kind of a hierarchy where you're really looking and saying, well, with broad strokes, where are we seeing changes in costs? And then use that to really hone in on where you want to drill down in, because if costs overall aren't changing, and obviously you'd have a metric that's looking at that, but where are things changing? You could also look at utilization. This utilization's gone up versus this. What's the cost impact of that? But I do think, there's just so much data that you could just get lost in trying to come up with some all-encompassing process that will do this. So I do think normally, whether you go by disease area or something, you could go in and look and say, well, where are we seeing some big changes? What are those outliers where something is definitely going on because it's changing, and do more deep dives there. And because if the costs really aren't changing, even if there is some kind of substitution going on, is it really relevant in terms of the broader conversation around growth in costs? So I think scope of this is going to be, really important, and a little bit of pragmatism as well, to really understand, well, there's some things going on here, and then digging into the detail. Absolutely, you need to do that to come up, I think, with anything that's actionable. But it's a tough analytical challenge, that's for sure.
Thank you. I really appreciate the reminder, maybe, or the shout out to the pragmatism. I think it's tempting to want to do this all, but I think it's not possible at all. So being very realistic about where we focus this, and I think, Rebecca, you're mentioning that as well with the microscope of where do we see spending growth, where do we want to apply this intensity analysis as a tool. I really like that reminder, so thank you. Other thoughts, ideas, reactions? Okay,
This is Keith again. Sorry, I had just one other thought.
Yeah,
And
go
I
for
see
it.
my hand still up. I mean, are any of the other states or anywhere else ahead on this? I mean, what have other people done that has been useful? Because I'm guessing if there are areas that this has happened, if those have already been pre-identified through other analyses, whether it's through literature searching or just through your contacts, that might help as well to kind of hone in on targets for a deeper dive.
Yeah, we've done quite a bit of lit review. It's wildly inconsistent. I wouldn't say there's any sort of clear direction or standard. I think the other states, the most tangible pieces are the two examples I shared in the slides from Washington Health Alliance, which uses the DRG approach. There's a link to their report if anyone wants to look deeper at that. And what Massachusetts is doing around upcoding. We're talking to both of them. The other states that we're brainstorming with are in this similar sort of throwing ideas at the wall to see what makes sense. Our counterparts in Nevada are focusing more on a utilization approach, but I don't know that anybody's really implementing anything specific for intensity other than what Washington Health Alliance and Massachusetts have already done. I think we're all struggling with this sort of in a similar state right now. Although I will say you all read probably different things than I do. So if any of you have seen anything like this in literature, have seen anything interesting analytically, we would really welcome hearing that. Feel free to send us an email with any ideas. Feel free to send us an email with any additional thoughts on this. I think this conversation is going to go on for a number of months. We can certainly come back to you and let you know how this is evolving. But I think the conversation with other states and with some of our technical assistance providers trying to think through this will continue for a while before we land on doing anything. Stephen, anything else that I didn't say you want to add?
Not really. I think we did a good job of identifying both the value and the challenges here, and that depending on what we pick to do, this could be a huge undertaking of academic paper type of look at versus, something more surface level and routine. So that is kind of the challenge before us.
And I would also say, again, with that academic paper slant in mind, if this is something that any of you or your organizations are interested in digging into, we're always happy to talk to you more and think about partnering. If there's something that you have in-house that maybe starts to get at this, we'd love to hear about it and think about applications. So if this is something you're interested in digging in your own data, definitely reach out and let us know. We can talk more. Rebecca?
Yeah, I just want to point out that how does intensity intersect with low value care that you have on this? This is a really key question. But before we label all increased intensity as low value, there is some increase in intensity. I think particularly among the interactions with PCPs as they do, more careful screening and counseling with their attributed members. That's a more intense office visit than a fly-by office visit, and we might applaud that. So I just want to be careful that we don't think all increased intensity is bad increased intensity.
Yep, thanks for that.
But certainly there's a lot of low-value care, so I applaud you for doing this.
Well, maybe doing this. Thank you. Okay, I think just one more reminder. Again, we really welcome any other thoughts on this. If you have any light bulb moments over the coming days, again, just let us know, shoot us an email, and I will turn it back to trying to wrap us up.
Right. All right. Thanks, everybody. A reminder for our next meeting. So our next meeting is actually right before Thanksgiving. So we are canceling that meeting. We'll send updates via email. So please be on the lookout for that. Also in that email, we're going to solicit feedback on how future TAG meetings should go in 2022. So be on the lookout for that. And that's all we've got today.
Any final questions or comments for us while we're here together?
All right. Well, hearing none, I think we can close this tag meeting.
Thanks so much, everybody.
Thanks
We
for
really
your
appreciate
time.
your time and your feedback.
Yes. Have a good rest of your Wednesday. Bye.